Hello everyone, and welcome to a presentation on pharmacologic therapy of obesity, integration into a comprehensive care model, sponsored by the Association for Bariatric Endoscopy. My name is Marty Roth, and I will be your moderator for this webinar. The course directors and presenters for this webinar are Dr. Shelby Sullivan and Dr. Nitin Kumar. Dr. Sullivan is Director of Gastroenterology, Metabolic and Bariatric Program, and Associate Professor of Medicine at the University of Colorado School of Medicine. Dr. Kumar is in Gastroenterology and Bariatric Endoscopy with the HSHS Medical Group in Effingham, Illinois. Both Drs. Kumar and Sullivan are on the ABE Advisory Board. Before we get started, just a few housekeeping items. There will be a question and answer section at the close of this presentation. Questions can be submitted at any time online by using the question box on the right-hand side of your screen. If you do not see the question box, please click the white arrow in the orange box located on the right side of your screen. Please note that this webinar is being recorded and will be posted on ASGE's website for future use. The presentation slides will be emailed to you after this call and will be available on ASGE's website within 48 hours. At this time, I would like to turn the webinar over to Dr. Sullivan.
Thank you, Marty. So I'm going to be talking about basic obesity pharmacotherapy. And I do have some disclosures. I have research and grant supports from a number of the weight loss device companies. Primarily, I've been involved in those, many of the US trials, and I'm also a consultant for a number of these companies as well, primarily in helping to develop lifestyle therapy protocols for their studies, as well as to educate physicians on the uses of their devices. So weight gain and the causes of weight gain are really multifactorial, and they include diet, inactivity, stress, inadequate sleep, genetics, but also medications. And we're going to focus this part of the talk on medications that patients may be taking, which may actually be contributing to their obesity. So when we think about pharmacotherapy, a lot of people think immediately about starting medications for weight loss. But really, when we're doing pharmacotherapy for patients, we're both looking at medications that may be causing weight gain that we could modify using medications that can cause weight loss instead of medications that can cause weight gain for certain diseases. And then we, on top of that, would think about medications that are specifically approved for weight loss, which Nitin is going to cover in just a few minutes. So in terms of medications that cause weight loss, there is a long list of them. For cardiovascular medications, they include beta blockers, calcium channel blockers. In terms of the anti-diabetes medications, we have insulin, which definitely causes weight gain. The thiazolidinediones, which although are good for non-alcoholic fatty liver disease in terms of reducing liver fat, they do increase weight, and the sulfonylureas as well. Steroids, both prednisone and methylprednisolone, can cause weight gain, and the estrogen modulator tamoxifen can also cause weight gain. There are also a number of antidepressant medications, many of which we use in GI, including the tricyclic antidepressants, can cause weight gain, as well as paroxetine. Although any of the SSRIs could potentially cause weight gain, this is really the biggest offender. So if patients are on Paxil, I usually try to switch them to a different SSRI or to a different medication altogether. Venlafaxine can also cause weight gain as well. In terms of the antidepressants, or the atypical antipsychotics, almost all of them can cause weight gain, although the least weight gain associated medications include aripiprazole, paliperidone, and ziprasidone. The anticonvulsants, many of them, gabapentin, which again, many of us use in GI as well as a neuromodulator, phenytoin, valproate, and carbamazepine all can cause weight gain in addition to lithium. Other medications that may cause weight gain, there have been some case series or some studies that have shown an association of weight gain with Benadryl, and benzodiazepine may also be associated with weight gain, although those are a little bit less clear. So the first step of pharmacotherapy is on medication review to evaluate for medications that can cause weight gain and identify if an alternative medication could be used for that particular disease process that the medication that's causing weight gain could be substituted for. In many cases, you may need to review this with the patient's PCP, their neurologist, or psychiatrist regarding medication change, especially when it's related to an atypical antipsychotic, some of the antidepressants, and mood stabilizers. So some alternative medications. And not all of these medications cause weight loss. Some of them are just weight stable. So in terms of the cardiovascular medications, hydrochlorothiazide, ACE inhibitors, ARBs, these medications are typically weight stable. So they don't really cause any increase in weight or decrease in weight. And so they may be a good alternative to somebody who has gained weight on a beta blocker or calcium channel blocker. In terms of anti-diabetes medication, and we're going to talk about this a little bit more in a minute, metformin is a good choice if they have relatively good control. And in general, the obesity or the diabetes treatment guidelines currently call for the first step of obesity or of diabetes treatment to be with metformin. You also have the GLP-1 analogs and SGLT2 inhibitors. The other advantage of both the GLP-1 and the SGLT2 inhibitors is these also may come along with weight loss. Metformin can also sometimes cause weight loss, but it's not in every patient, and the weight loss achieved with metformin is not very large, but it does not cause weight gain. The other beneficial effects of the other two medications are that they can actually reduce cardiovascular risk. So they have additional benefits beyond just their effects on lowering blood glucose. In terms of the antidepressants, bupropion can be used instead of some of the weight gaining medications. That medication is actually part of the weight loss FDA approved medication Contrave. And again, the SSRIs, which in some cases can cause weight gain, it's really on an individual basis for those other SSRIs. But again, paroxetine definitely causes weight gain. In terms of the anticonvulsants, you can use topiramate or zonisamide, which are alternatives that actually promote weight loss. Both of these medications do have weight loss as a side effect. In terms of the least weight gain inducing atypical antipsychotics, as we said before, the prazodone or Geodon is really the least of all of them. And then we have paliperidone and aripiprazole, which also, although they can cause some weight gain, it's usually the least amount of all of the atypical antipsychotics. So how do we initiate therapy for these? So the other thing that's really important to talk about is that pharmacotherapy in obesity also can be used in terms of initiating therapy for comorbidities, because there are obesity-related comorbidities that we also want to think about when we're starting these medications. So obesity affects every organ system and is associated with many comorbidities. Treatment guidelines often use BMI as a parameter to trigger testing. This is true for, in particular, we'll talk about in just a second, diabetes. And treatment of comorbidities with medications that also cause weight loss can be beneficial for patients, in particular patients in whom we're trying to get weight loss. And I'm going to go over just one example of this with diabetes testing. So this is from the American Diabetes Association. Although I don't expect gastroenterologists to become diabetologists or to routinely treat diabetes, it is important to note that some of the medications that we use to treat diabetes can also be used for weight loss or do also get weight loss in patients. So testing really should be considered in patients who are overweight or have obesity and have one or more of the following risk factors. And what you can see is that many of the patients that you'll see who have obesity meet one of these criteria. And I will say that in my practice, every patient who comes in who has a BMI above 30, I do check hemoglobin A1C on these patients. And the vast majority of patients that I see have prediabetes at least, and in some cases I am diagnosing them with diabetes. That's important to note because, again, there are medications that you can use to help treat that. And hopefully we can go on to this. And so this is one of the slides that I like to show just to kind of demonstrate that. So even in patients who have prediabetes, metformin was actually shown to have some weight loss, and this was statistically significant. Although it was not a huge amount of weight loss, there was some weight loss that was present with metformin. Lifestyle therapy, of course, got more weight loss in general. But the other thing that's important is that these patients had a reduction in the cumulative incidence of diabetes. So metformin did prevent patients from progressing into diabetes. And of course, lifestyle therapy with weight loss was even more beneficial. But the combination of those two together, in addition to any of the therapies that we may also be providing, can provide some more long-term prevention of diabetes, which ultimately is going to be very important for all of the patients that we treat. In addition to that, in particular with some of the new anti-diabetes medications, is that they may also be coming to gastroenterologists in general because they are being looked at for their effects on non-alcoholic fatty liver disease. And in particular, the GLP-1 analogs, this is just one of them looking at liraglutide, which in this small study from the Lancet was shown to cause a resolution of non-alcoholic steatohepatitis in 39% of patients compared to 9% in the placebo control group. Although liraglutide is not approved for the treatment of NAFLD at this point, and the AASLD is not recommending it for patients who have NAFLD and don't have diabetes, this may be the wave of the future. So not only can these medications help us with weight loss, but they also may be something that, as we're treating obesity, we will also be treating obesity-related diseases, especially the ones that are specific to the to GI, including non-alcoholic fatty liver disease. So although these medications, and learning how to use these medications may be a little bit scary up front, just remember we as gastroenterologists also use a lot of other medications that have a lot of side effects that we're able to manage, in particular with the biologics that we use. So these medications are no scarier than those medications. So I'm going to go through a couple of examples of how you can alter medications or suggest to primary care physicians to change medications in order to help patients with their weight loss. This is a 52-year-old woman with hypertension and a history of weight gain after her third pregnancy, then continued to gain weight over time. She's tried Weight Watchers in the past with minimal weight loss, followed by weight regain with even more weight than she had initially. She's currently not exercising. She has no evidence of snoring or daytime sleepiness, and her current medications include metoprolol 50 milligrams twice a day. Her current weight is 212 pounds for a BMI of 38.7 kilograms per meter squared, and she has a blood pressure of 125/78. The remainder of her exam is normal, and there were no labs to review. And this is pretty common among many of the patients that I see. They come in previously not having any recent labs or having any evaluation for obesity-related comorbidities. So after reviewing options, the patient would like to start lifestyle therapy, but is considering an intragastric balloon. So based on that, our initial plan was to check lipids, hemoglobin A1C, vitamin D, B12, CMP, and a CBC. These are pretty standard labs that I get in all patients who have obesity. We started a 1,200 kilocalorie diet with 60 grams of protein, initiated walking 20 minutes per day, 4 to 5 days per week, asked her to record her food and activity at least 5 days per week. We stopped the metoprolol and started hydrochlorothiazide, and we had the patient return in 1 month. So the patient lost 4 pounds since her first visit. She has been walking the 20 minutes, 4 days per week, and has been recording all calories. Her labs did reveal a hemoglobin A1C of 5.8 and an ALT of 45. So at that point, metformin was added, 1,000 milligrams BID. And in general, I start this at 500 milligrams once a day and increase by 500 milligrams until once a week, until we get to our goal of 1,000 milligrams twice a day. And this is to help mitigate some of the diarrhea and other GI side effects of metformin. We also initiated a workup for her increased ALTs, and that included labs and an ultrasound. We increased walking to 30 minutes, 5 days per week, and had her return in a month. So that is one example. I will say that in general, anytime a patient has an ALT greater than 35, I usually do initiate a workup for non-alcoholic fatty liver disease and do get labs to rule out other causes of liver fat. So in our second example, we have a 33-year-old woman with a history of weight gain after college. Weight increased again after starting nortriptyline for migraine prevention. She has tried self-administered weight loss programs, including the South Beach diet and exercise, but really hasn't been able to lose weight. She currently does exercise, doing yoga 2 days per week. She doesn't snore, and her current medications include nortriptyline 50 milligrams at night and sumatriptan as needed. Her weight was 191 pounds, BMI 32.8, blood pressure of 111/68. The remainder of her exam is normal, and again, comes to clinic with no labs to review. So after reviewing options, she would like to proceed with intragastric balloon therapy, but also agrees to medication change prior to balloon placement. So the plan in this patient was to, again, check labs. In addition to that, when I am going to place a balloon, I also check for H. pylori and coag. So we also tapered her off of Neurontin and started topiramate 25 milligrams twice a day, but of course asked her neurologist first, so that had to be approved first by her neurologist before switching over to the topiramate. We also asked her to start recording food and activity, and to add aerobic exercise with the elliptical machine, 20 minutes 3 times per week, and to continue yoga. She was also going to follow up with the dietitian for pre-balloon placement nutrition evaluation and post-intragastric balloon placement diet instructions. And that is the end of my half of the presentation, and about the just basics of obesity pharmacotherapy. And next is Dr. Nitin Kumar, who will be talking about the FDA-approved medications for the therapy of obesity.
Thank you, Shelby, for the introduction. So I will be discussing the FDA-approved medications for the treatment of obesity, which should be part of a multidisciplinary weight management program, which should also include diet and behavior modification, even if the patients have attempted these before and failed and come to you for medical therapy. These can be used long-term, and they're bracketed by FDA-guided indications, so a body mass index of over 30 or over 27 with comorbidities such as diabetes, hypertension, and hyperlipidemia. And in general, this will be a recurring theme, but these should be avoided in women who are attempting to become pregnant, and that could be a decent proportion of the patients who come to you for this therapy. So starting with the older medications, phentermine, which is a sympathomimetic, and it is a controlled substance. It's a Schedule IV substance. This has pluses and minuses, but one advantage of this is that the patient has to come back to you for refilled prescriptions, and that can keep them in the loop and as part of your monitoring program. This is approved for 12 weeks of use in most states, and that varies, but in general, most states limit the use of this to 12 weeks. And this is pregnancy category X, so it should not be used in any circumstances. Dosing is 8 milligrams orally 3 times a day before meals, or 15 to 37 milligrams orally once a day before breakfast or 1 to 2 hours after breakfast. And that can be started at the lower end of that and titrated upwards. It should stop at 12 weeks, as we said. It should be used in caution in patients with renal impairment. So this medication has been around for a long time, and a trial that was controlled in the 1960s showed that it was significantly more effective than placebo for weight loss. Adverse effects include what you would expect with a stimulant medication: tachycardia and palpitations, hypertension, tremor, insomnia, dry mouth, diarrhea, and the medication should be avoided in patients with pre-existing cardiovascular disease, pulmonary hypertension, hyperthyroidism, glaucoma, monoamine oxidase inhibitor use, patients who are breastfeeding, and patients with a history of drug abuse, because this does have that potential. The next medication, much more recently introduced than phentermine relatively, is orlistat, and this is marketed as Ally over-the-counter or Xenical in prescription strength. So this is a gastrointestinal lipase inhibitor, and it decreases fat absorption. It works better, therefore, if the patient is on a high-fat diet. It's not significantly absorbed, so it has a good adverse effect profile, but it is pregnancy category X. So dosing, and this is Xenical, the prescription form, is 120 milligrams orally with each meal containing fat. The over-the-counter form, Ally, is 60 milligrams. There's no adjustment recommended for renal or hepatic impairment, and a study now on both groups, placebo and orlistat, in this study had intensive lifestyle therapy, showed that it was statistically more effective than the placebo form at 1 year and at 2 years. Adverse effects include oily discharge, incontinence, and flatus for gastrointestinal side effects, as well as increased defecation. There is also a possibility of cholelithiasis or renal oxalate stones, and you can place these patients on a low oxalate diet if you use this medication. In rare cases, hepatic injury has been reported and decreased fat-soluble vitamin absorption as well. Lorcaserin, or Belvic is the brand name, is a serotonin 2C receptor antagonist, and this was the first of the most recently approved group of medications. It's a controlled substance, and potential drug interactions with serotonergic or dopaminergic medications, so SSRIs, SNRIs, tricyclic antidepressants, lithium triptans, tramadol, and it's pregnancy category X. It should be avoided in valvular heart disease, patients with suicidal ideation, priapism. Dosing is 10 milligrams orally twice a day, and this has a stop rule, so this should be stopped if the patient does not achieve at least 5% total weight loss at 12 weeks. Should be used in caution in patients with severe hepatic impairment, and caution in moderate renal impairment, and avoided entirely in severe renal impairment. Once again, these groups, placebo and lorcaserin, both included intensive lifestyle intervention, but it did show significantly more weight loss than the placebo group at 1 year. Adverse effects include dry mouth, headache, dizziness, fatigue, nausea and constipation, cough, and this should be avoided in patients with valvular heart disease and leukopenia. Phentermine and topiramate is marketed as Qsymia, so this is a combination of phentermine, which we saw before, and the neurostabilizer seizure medication or migraine medication topiramate or Topamax. And notably, these are both in extended release form, which is not the form in which you can otherwise acquire phentermine. This is a controlled substance as well, and it is also included in the Risk Evaluation and Mitigation Strategy, or REMS, by the FDA, which means that because it is teratogenic, including cleft palate risk in first trimester exposure, patients need to have a pregnancy test before starting and then monthly while they're on the medication, and they must use contraception while they're using this. This is more an issue for the pharmacy. The pharmacies have to enroll, so not every pharmacy offers Qsymia. And additionally, the provider can and should enroll, which involves an online training program which will apprise the prescriber of all the risks of using this medication in females who may become pregnant. Additionally, it is pregnancy category X and should not be used during nursing. It may cause dysfunctional uterine bleeding while on oral contraceptives, and it may enhance the effects of alcohol. Dosing starts at 3.75 milligrams, 23 milligrams for 2 weeks, followed by double that dose, 7.546 for 2 weeks, followed by an option to increase to 11.2569 or 1596 if that's well tolerated for 2 weeks. This medication should be stopped if there is not a 5% weight loss at 12 weeks on the highest dose that's achieved. And dosing should not exceed 7.5/46 in patients with moderate hepatic impairment. Should not be used at all in patients with severe hepatic impairment. And similarly, dosing should be reduced if there's moderate or worse renal impairment. There's a dose-dependent effect in this trial, which showed greater efficacy than placebo at a low dose at 1 year and much greater efficacy at the high dose at 1 year, reaching nearly 11% weight loss, and that is the strongest weight loss we see in these medications in randomized trials. Adverse effects include dizziness, paresthesias, dysgeusia, insomnia, dry mouth and constipation, metabolic acidosis, elevated creatinine, hypoglycemia. And contraindications include glaucoma, hyperthyroidism, concurrent or recent MAOI use, pregnancy or nursing, suicidal ideation, acute myopia, or angle closure glaucoma. And many of these are the same that we see with phentermine because that is part of this medication. The next medication is naltrexone bupropion, which is marketed as Contrave, and both of these are extended release. So this is the opioid antagonist naltrexone used with the aminoketone antidepressant bupropion, which is brand name Wellbutrin. This is not a controlled substance, but it is pregnancy category X. So if you are interested in using a medication that does not require everything that goes with using a controlled substance, this is one of the few options. Dosing starts with 1 tablet every morning for a week, then 1 morning, 1 evening, then 2 morning, 1 evening, and then eventually in the 4th week, 2 morning and 2 evening, and that's the eventual long-term dose. Like the other medications, this should be stopped if there's not 5% weight loss at 12 weeks. If there's hepatic impairment, only 1 tablet should be used per day, and in moderate or severe renal impairment, 1 tablet twice a day, but not recommended in end-stage renal disease. Additionally, if there's a CYP2B6 inhibitor use, this should be limited to 1 tablet twice daily. And so this is most easily found using whatever you otherwise use to check for drug interactions before you prescribe a medication. In the Core 2 study, this showed significantly more efficacy than placebo, reaching approximately 6 to 7% total weight loss at 6 months, and also maintained that at beyond 1 year. This medication should not be used with a number of medications, including MAOIs, SNRIs, tricyclic antidepressants, antipsychotics, beta blockers, antiarrhythmics, and as we said before, certain hepatic enzyme inducers. So again, these should be checked before prescribing. And then drugs that lower seizure threshold and dopaminergic drugs like levodopa and amantadine. Adverse effects include suicidal behavior, which is a black box warning for this medication, nausea, vomiting, constipation and diarrhea, headache and dizziness, insomnia, dry mouth, seizure, which can be reduced by avoiding co-administration with high-fat meals, hypertension and tachycardia, hepatotoxicity, and glaucoma. Contraindications include seizure disorder, anorexia nervosa or bulimia, chronic opioid use because of the naltrexone, recent discontinuation of alcohol, benzodiazepine, barbiturate, antiepileptics, uncontrolled hypertension, MAOI use. Liraglutide, which Dr. Sullivan was alluding to earlier, is marketed as Saxenda for weight loss, and it's a GLP-1 agonist. This is not a scheduled drug, just like Contrave, but it is in the REMS for medullary thyroid carcinoma and acute pancreatitis, meaning that if you prescribe this medication, you will receive a letter from the manufacturer explaining the risk of these two. Dosing is injected subcutaneously at 0.6 milligrams per day for a week, and going up by 0.6 milligrams each week until reaching 3.0 milligrams. This should be stopped if there's less than 4% weight loss at 16 weeks, and should be used in caution in renal or hepatic impairment only due to lack of data. The scale trial showed at 56 weeks there was significantly more weight loss than placebo, approximately 8% total weight loss. Contraindications include a personal family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2 and pregnancy. Adverse effects: nausea, diarrhea, constipation, dyspepsia, loss of appetite, hypoglycemia, headache, fatigue, and dizziness, elevated lipase. And it's important to watch for signs of medullary thyroid cancer and pancreatitis. These are explained in detail in the letter once the REMS program is initiated, which you can initiate as well before prescribing this online. Hypoglycemia, especially if it's used with a sulfonylurea, tachycardia, renal impairment, and in renal impairment, it's important to escalate the dose carefully. Hypersensitivity, cholelithiasis or cholecystitis, and this should be discontinued if there is any depression or suicidal ideation. So this is a summary of the relative efficacy. This is placebo-subtracted efficacy compared with baseline at the highest approved dose, and we see that phentermine topiramate, which is Qsymia, and naltrexone bupropion, which is Contrave, and liraglutide, which is Saxenda, generally have the most efficacy, and of these, the latter two are not controlled substances. Weight regain does occur, so these medications, just like an antihypertensive or any other medication that's used for chronic disease, loses its efficacy if you stop taking it. So in this case, you see placebo is the blue line. The gray line is Lorcaserin or Belvic. And in this trial, once the patient was changed to placebo, weight regain happened and the patient reached approximately the level that the placebo patients were on, whereas patients that continued Lorcaserin continued to maintain their weight loss. So in conclusion, there are several FDA-approved medications for weight management. They're relatively safe, although it is important to be aware of what contraindications there are and what side effects can occur. And they can be used long-term, although it's important to keep in mind the stopping rules that we discussed. They are highly effective in select patients who do extremely well, and then many other patients will achieve the results seen in the trial. And then there will be patients who don't respond, and in those patients, therapy can be stopped. These medications can also increase the efficacy of other interventions, such as endoscopic therapies, so they are good adjunctive medications to use. But overall, they should be used as part of a comprehensive program, and so they should be used with diet modification and exercise. And with that, we will go on to questions.
Thank you, Dr. Kumar and Dr. Sullivan, for this insightful and informative presentation. And also, we want to thank everyone for joining us for this ABE webinar on pharmacologic therapy of obesity and integration into a comprehensive care model. Before we move into the question and answer session, a brief note about ABE programming that may be of interest to you. All ABE members are invited to a half-day didactic course on Friday, June 1st, in Washington, D.C., just prior to DDW. This is a CME course and will be followed by a reception. These events are free to ABE members. To register, please visit the ABE website at www.barryendo.org. That's www.barryendo.org. At this time, Drs. Kumar and Sullivan will address questions received from the audience. As a reminder, you can submit a question through the question box. If you do not see the question box, please click the white arrow in the orange box located on the right side of your screen. It will be toward the bottom. So the first question I have for you this evening, how long is pharmacotherapy tried before moving on to other treatments like balloons?
Well, I would say that pharmacotherapy doesn't necessarily need to be stopped before moving on to any other therapy. It can be used as an adjunct. Of course, you have to keep in mind that if there are contraindications with other medications that they will need to use or other reasons to not use the medication, then it's worth stopping. Also, if the medication is not effective at all, then you should apply the stopping rule and stop the therapy. But otherwise, the medication can often be continued long-term. So if you have a patient who is above the stopping rule for a medication, but still wants further weight loss, they can proceed to an endoscopic therapy or a bariatric surgery, and they don't need to stop the medication. And in fact, stopping the medication could result in weight regain right as they're starting something else. So when possible, the medication, if it's effective, can be continued long-term.
All right, thank you very much. The next question I have, if a patient comes to you for an obesity procedure and is currently on an antidepressant, are you recommending that they switch their medication even if they are getting good results from their antidepressant drug that they are on?
Well, I think it depends. It depends on what antidepressant they're on and whether they can change. If they can change to something like bupropion, which is Wellbutrin, then they might find that helps their weight loss. It is important to keep in mind there might be a little bit of a washout period. You don't want to overlap these medications too closely because they can interact if one is stopped and another one started right away. But if they are going to get an endoscopic therapy, the endoscopic therapy should be effective on its own, and it may overpower the antidepressant that they were on, and they may still be successful. But to optimize their chances, You can discuss this with whoever's prescribing their current antidepressant, whether it's the primary care or a psychiatrist, and ask them if they could be changed to bupropion or a different medication that may be more effective for weight loss, or at least may not lead to weight gain as much as what they were on before. So when possible, I would try to change it.
And just to echo what Nitin said, it sometimes it is not possible to change it. I have had the experience before of trying to take somebody off of Paxil and trying a different medication, and the patient came into my office crying when they were on their the last part of the taper of Paxil, just because her depression was back, and we really weren't going to be able to. She didn't want to stop that medication. She wanted to go back on it just to make sure that her symptoms were controlled. She didn't want to try Wellbutrin or a different SSRI. So it really has to be patient dependent, and you have to be willing to say, this isn't working. We're going to have to go back on the medication that you're on, and just try to do what we can do with other therapies that we're providing.
I would agree, and I wouldn't change too many things at once. So I wouldn't stop their medication and then put the balloon in right away, because it will muddy the picture of what's going on with their, for example, SSRI withdrawal with starting balloon therapy, and it'll be too much. So I would get all these things sorted out and let them become stay stable on their old medication or become stable on the new medication for a while before trying an endoscopic therapy, just to optimize your chances of success.
All right, thank you very much. And the next question I have is, I would be reluctant to prescribe any weight loss drug to a female who was considering getting pregnant. Would you agree that if a woman is considering getting pregnant, she should hold off on any weight loss medication?
Well, that's what the FDA says. It says women who are considering pregnancy should not start weight loss medication. And I think that is reasonable. Now, there are exceptions in which someone's trying to become pregnant and weight loss will help them to become pregnant. So if that's the case, then depending on what medication you're using, you may want to have them use contraception, lose weight, and then taper off the weight loss medication and try to conceive. But in general, I think they're better off not starting weight loss medication if they really think they're going to become pregnant soon, going through the pregnancy and then coming back for weight loss intervention, because then there are medications that you can use.
I agree with Nitin, and actually I ask patients at every single visit. It's part of my template is to ask about last menstrual period. If patients are on Qsymia, I check. I actually do a urine pregnancy test, and not just asking about last menstrual period. But I counsel all of my patients about not getting pregnant while they're on any of these medications, and always make sure that they have an effective form of birth control, or are postmenopausal.
All right. Well, I want to thank everyone for joining us today. We hope this information is useful to you and your practice. Following today's webinar, you will receive a survey. Please take a brief moment to complete it. Your input will help us in improving our future webinars. This concludes our webinar. Please stay tuned for future educational opportunities from ABE. Have a good evening.